We are live now, doctor.
Good evening, friends. Jai Hind and Jai Maharashtra. This is the MOS clinical grand rounds, and today the topic is retina. At the outset, I would like to express my gratitude to our MOS president, Dr. Anaga Herur, for conceiving the clinical grand rounds, which is gathering a lot of popularity, extremely useful for all ophthalmologists, whether it is subspecialty ophthalmologist or general ophthalmologist. And we have curated today's program so that both subspecialty as well as general ophthalmologists will benefit. Without further delay, I am handing over the mic to our president, Dr. Anaga, to say a few words, and then over to Dr. Swapnesh Sawant. Dr. Swapnesh Sawant is vitreoretinal surgeon from Mumbai, and he has done a fantastic job today of getting together a galaxy of speakers and vitreoretinal specialists who are going to conduct the grand rounds today. Over to you, Dr. Anaga.
Thank you so much, Dr. Preetham, and a very good evening to one and all, and welcome to one more episode of MOS Clinical Rounds. So, a few months ago, we hit upon this idea that there are so many day-to-day cases that we see in our OPDs, whether it is external surface, retina, and there are a lot of dilemmas in the minds of the general ophthalmologist as to what would be the best line of treatment so that we give the best visual outcomes to our patients. So we have already had 3 episodes, and now here we are with one more episode with retina. So we have had now brought out a few cases that we daily see in our OPDs, and Dr. Preetham Samant and Dr. Sapnesh have actually curated this entire program, and so grateful to both of them. Also, deep gratitude to Dr. Chetan Rao sir for gracing this webinar with his presence, and to all our dynamic speakers and brilliant panelists. So, and I'm sure the entire audience is going to stay glued to this webinar today, and we are going to learn a lot. So, over to you, Dr. Swapnesh, for moderating this session. Thank you.
Sure. Thank you, Dr. Anaga Madam and Preetham sir, for this opportunity. And I would like to express once again my thanks to Dr. Chetan Rao sir for accepting this invitation. Dr. Anaga wanted a national faculty for this clinical round, and who better than a senior Shankar Netralaya consultant himself to guide us through all this. Sir is also the academic in charge for the VR fellowship, and he has taught as basic as indirect ophthalmoscopy to all the budding VR surgeons who are now 15 years, 20 years into practice. So sir looks young, but he's a very, very senior consultant, and we look for major inputs from him. Thank you, sir, for joining us.
You're welcome.
So we start our first case. It would be presented by Dr. Amit Nene from Thane, and senior consultant Dr. Bomat sir from Sangli would be the panelist for this case. Dr. Nene, please share your presentation. He would be speaking on focal laser role in today's anti-VEGF era in DME.
Thank you so much, sir. So at the foremost, I would like to thank MOS, Dr. Swapnesh and Dr. Preetham, sir, for giving me this opportunity. So I will start with my presentation. Is the screen visible?
Yes.
Yes. So the topic I chose for today's lecture was the role of focal laser in the era of anti-VEGF. So somewhere focal laser is getting absorbed because so many anti-VEGFs are available in the market. Wherever we go, a plethora of anti-VEGFs are available, calling all the doctors, please pick me, please pick me. Even the general ophthalmologists are nowadays practicing medical retina, and whenever there is any swelling in the retina, we just inject without looking here and there. So what happens when these cases come to us? So these are very typical cases who present with hard exudates, and there is no clinically evident CME there on the OCT scans. So what should one do in such cases? So the clinical question here is, does focal laser still have a role in selected patients with persistent hard exudates and dry macula? These exudates are usually formed due to the breakdown of the blood retinal barrier and leakage from incompetent microaneurysms and capillaries, causing deposition of lipoproteins within the retinal layers. So this further results in chronic inflammation, photoreceptor damage, subfoveal fibrosis, and permanent visual loss if these exudative clumps gather up at the fovea. So how does focal laser works in these cases? We directly aim at those leaking microaneurysms, as a result of which there is reduction in the leakage. It stabilizes the blood retinal barrier and further leading to prevention of lipid accumulation. So I will be presenting few cases where the role of focal laser is very evident. The power and the settings which I use for this focal laser is I use a 50 micron spot size with 150-250 power. Duration is 10 to 30, and I first give some light gray burns at the posterior pole, and then I directly treat over those hard exudates. So this is the first case of a 67-year-old female, diabetes mellitus since 10 years, presenting with severe NPDR and CSME. So you can see that ring-shaped exudative clump at the macula. So the edema is there on the OCT scan, but I decided to go with focal laser for this patient. And just with the focal laser, without any injections, I was able to achieve resolution of the macular edema, as well as these exudates disappeared over a period of time. So it takes at least 3 months to see the beneficial effects, but by 6 months, most of these exudates just resolve. So this is one more case of a patient of high risk PDR with CSME in both the eyes. You can see how these exudative clumps have all clumped up at the fovea in the right eye. So these are the post focal laser photographs. The images are blurred because the patient had developed a little bit of PSC cataract, but you can see that those exudates have just disappeared. This is one more case of old BRVO post multiple anti-VEGF injections taken elsewhere. The fovea was dry, but these exudates were still persisting. And if left alone, there is a chance that they can clump at the macula. So I did a focal laser for the patient, and this patient also responded beautifully. One more case of a patient of clinical significant macular edema post multiple anti-VEGF injections. Again, focal laser was done, and this is the photograph taken at 3 months follow-up. More or less, each and every hard exudate just disappears. These are severe more cases of CSME post multiple anti-VEGF injections in the past. So again, as you can see, the exudates have started to disappear. So this is a photograph taken just 1 month apart. But over a period of time, those exudates will also disappear. This is one more case of severe NPDR with CSME. Focal laser was again done as the macula was dry. You can see that those exudates have started to disappear. This is one more severe case of severe NPDR with CSME. Focal laser was done over these exudates as well as to the leaking microaneurysms, which were found out by FFA. So FFA also plays a crucial role whenever you are planning for laser in such cases. So the take-home message is anti-VEGF treatment remains the gold standard for all fovea involving lesions or for all macular edemas. But focal laser still remains clinically relevant, particularly when there are persistent hard exudates. And also the important point is focal laser needs to be done only once, or it can be repeated again if required. But the cost burden on the patient is reduced. So the future of retinal therapy lies not in replacing the old treatments, but in integrating them wisely for better patient outcomes. Thank you.
Thank you, Amit. That was a perfect start to this webinar. Bomat sir, your comments followed by CR sir's comments.
Yeah, so he's brought up a very important point where the focal laser importance is not highlighted even during the training period when the our retina specialists are getting trained. So previously, the laser was the gold standard for everything, and especially for the macular laser. We are still doing PRP, but we have forgotten about the utility of the macular focal laser. And Dr. Amit has brought out beautifully the utility of these. And it's especially important in case of resistant DMEs, where we take the aid of fluorescent angiography. And many of these aneurysms which are not visible to the naked eye, they will be highlighted by the fluorescein angiographic pictures and taking a printout of that particular frame where it highlights all the aneurysms can be kept beside the slit lamp, and then based on that anatomical landmarks, we can target all those leaking microaneurysms. More than one sessions might be required, and as has been rightly pointed out, we have to give it time. So it may be 3 months, 6 months, or even up till a year, and gradually these hard exudates will reduce and the edema will also reduce. So it's extremely important role to play in macular edema management of all etiologies, including vein occlusions, diabetic maculopathies, and also vascular malformations, coats, and other vascular malformations. So laser plays an extremely important role in these retinal vascular diseases. Apart from this, metabolic control is absolutely important, and anti-VEGF can be used as and when required to combine with these focal laser treatments.
Sir, a typical case where there is macular edema and we advise the patient that there would be monthly injections into three, which are required. What would be your recommendation of timing of this focal laser? When is the best time to do this focal laser? Because the patient is going to come for 3 months.
So in cases of non-central DMEs, where there is no actual involvement of the central 500 micro, you can say central foveal part of the, on the OCT, there is no edema there. So there the pharmacological treatment is not a must. So for non-central DMEs especially, and for sursinates which are quite away from the fovea, there we don't need to do the anti-VEGF treatments. There you can directly go for the focal laser treatment. Where you have got significant center involving DMEs, those patients we can attempt drying up the macula with the anti-VEGF agents and then supplement with laser. So you have to select cases where people will require both anti-VEGF and macular laser. Some patients will require only macular laser. So you will have to select the patients based on their OCT and clinical picture.
So would you recommend between the second injection and the third injection in the center involving DME would be an ideal time, because the edema also would be on the lower side?
So you will
So
have
is it-
to see the OCT, how it's behaving and how much the edema is reducing. So if the edema is very massive, obviously the focal laser cannot be done because you will not be able to identify the aneurysms, as well as the laser reaction will not manifest properly. So in case of significant retinal thickening, or we achieve the maximum possible reduction in the macular thickening and then attempt the focal laser.
Yeah. Thank you, sir.
So it might require 1 injection, 2 injection, or more than that. So it depends on the individual case and the extent of the retinal thickening.
Over to Chetan Rao, sir.
So I agree with whatever Dr. Sharad has said. I mean, there's nothing to add, but focal laser also plays a role when, nowadays there is this debate going about anti-VEGF in patients with kidney disease and stuff like that. So in those cases, we really don't like to give anti-VEGF because there are plus minus evidence of anti-VEGF causing worsening of nephropathy. So in such cases, I think we resort to this very time-tested treatment, laser. And right now you focus only on the focal laser. Many of us actually decide to do even grid laser. And there comes your usefulness when you have a lot of edema. So you can do grid laser after you give anti-VEGF, and when the edema comes down, then you supplement with a grid laser that helps. Focal laser may the problem is that you actually have to look at the aneurysm. So you should be able to see the aneurysm. So many times, as he said, rightly said, when you do an FFA, you see many more aneurysms. But when you're doing the laser, it's kind of, you keep the FFA right in front of you to do the laser. So that guides you. Otherwise, clinically, when you look at it, you only treat the most visible superficial microorganisms. And we all know that many of the microorganisms are quite in the deep layers as well, which when we actually need a grid laser treatment. So focal laser is very useful, still very useful, especially, again, if you really have a patient who is not keen on taking anti-VEGF. Nowadays, there are so many things, Google and all, people get so afraid of what they read. It's the simplest non-invasive treatment available to us and does wonders. The only thing is we need to counsel them, that takes time.
So, any role of statins in these particular cases with hard exudate? Do you advise for all cases or select cases, refer them to physician for statins for resolution of hard exudates, or you only depend on diabetic metabolic control in DMEs?
See, the evidence levels are not really great. People have, there are people who believe that you give statins and the heart X rays will disappear. But the heart X rays are not exactly because of the cholesterol that is there in the system. It's just a leakage which happens, and it is so much profound. So you need to actually treat the other aspects of this. Statins are just a drug which works on the liver at the level of cholesterol, but it really doesn't translate into that. But there are people who believe that, like fenofibrate, probably helps in a different way. It takes care of the blood-retinal barriers to some extent, and hence it helps. But I'm not sure about statins. I don't believe in it, but there are people who do it.
Great. So thank you, Dr. Amit, for a lovely presentation. Dr. Sharath for your inputs. And with that, Swapnesh, we'll move on to the next case.
So yes, sir. The next case is by Dr. Deepti Kulkarni. She'll be speaking on refractory DME. And Dr. Manish Bapai, sir, from Nasik, prolific surgeon, would be the panelist for this particular case.
Yeah, good evening. Thank you, MOS, for this opportunity. I'll right away dive into the cases. Yeah. So I've taken two common scenarios that all of us face in the OPD. I've purposely not added the FFA because most of the times FFA is not available for a general ophthalmologist to make a decision. This is the first case. This lady first presented to me in 2023. That time she was 85 years old. This is from a peripheral center where I go for visits. Her vision was 636 then and N36. She had already received multiple injections of bevacizumab and IVT elsewhere. At this point, I had suggested her ranibizumab and she had chosen Accentrix, and she was regular with treatment for the next few months. Over the years, I think we gave her 2 or 3 injections at that time, and she had been following up with me. She used to take sometimes after a couple of months, and then she used to refuse injections for the next few months. Over the entire last year, she refused to take any injection whatsoever. And her vision had been stable at 618 and N12. She's fond of reading, but she was managing with this vision, and so we didn't try to force her to do anything else because nothing had worsened or nothing had changed in the OCT picture and the vision as well. This year, for the first time, she complained of metamorphopsia again in February. That's when the picture was looking almost the same that it was before. And I gave her brolucizumab, and which we gave in March. She came back in April. Her metamorphopsia was gone. And she came back surprisingly today afternoon. So this OCT is from today afternoon. Her vision has improved. Metamorphopsia is not there. Although the OCT picture still looks the same, more or less the same to me. But her vision has improved now. So we have decided to just keep a watch again, because now she's said that now she's almost nearing 90 and I don't want to take any kind of treatment. I don't want to get any injection after this. So let's see what happens. Next is another case which of a 65-year-old gentleman, diabetic and hypertensive. Sorry, I forgot to add, the previous lady had a good control of her systemic diseases. This gentleman did not have a good control of all his systemic parameters. His vision was 660, and we suggested bevacizumab. He took Avastin at that time. He came back after a month. The lower OCT shows the subsequent OCT after the injection. We can see signs of stasis, we can see DRIL, we can see HCW, everything that points to ischemia, everything that points to chronicity is there in this OCT. We advised shifting to a different anti-VEGF. He chose a biosimilar and I gave Razumab. That's what I use commonly. This is around 3 weeks after Razumab injection. His vision has improved a bit, 624. Hypertension is quite well controlled now. But at this stage, I have advised a dexamethasone implant, Ozurdex. So I've just put a few slides to ignite this discussion, that these are the systemic considerations that we have to consider before we treat a patient, along with the age and control. hypertension also, which most of the time the patients tend to overlook. We might not, but the patients feel that, okay, BP is there, so what? But my sugar is controlled. But all these factors contribute to the stasis. All these factors contribute to the worsening of or non-response to the treatment. Sleep apnea, the renal status, and even hypercoagulability caused because of hyperlipidemia also can worsen these conditions. So the doubt most of us that we face is which drug to shift to. Now, all the studies show that although Avastin or Brolucizumab or Bevacizumab is the commonest injection that is used, it is also the commonest which is shifted to something else. And we then end up shifting to Ranibizumab, Aflibercept, Brolucizumab, whatever the patient can afford at that time. Laser, as Dr. Amit has beautifully presented, and also surgery in certain cases when we know that the vitreomacular interface is involved or it is worsening. So when do we shift to steroids is a major point of discussion now, because since steroids are again making a comeback, it shows all these studies show that if there are more than two parameters as of subretinal fluid, hyperreflective cystoid walls, and a vitreomacular interface which is not optimal, then if two of these markers are present, it is sure that the anti-VEGFs are not going to act as much as we want them to, and it's worth shifting or giving steroids even in treatment naive patients in such cases. There are a lot of chatter about anti-VEGF and steroid combinations too nowadays. I have personally not combined these drugs, and although there is a faster visual improvement initially, the long-term outcomes are not superior to using just steroids. There's a lot of discussion about functional diabetic retinopathy. You just mentioned fenofibrate. So in these cases, all these extra parameters are being studied, like flicker ERG, OFA, and contrast sensitivity and perimetry and the role of fenofibrate in all these conditions is being studied to prevent diabetic retinopathy in a patient who is at a risk of developing further stasis. Thank you.
Dr. Bapai sir is there. Thank you, Dipti, for that presentation. And you have highlighted some latest investigations also. Bapai sir, your comments.
Yeah, so as Dipti already described, I think there are, we need to look at the patient clinically very well. In the last presentation as well as this presentation, there is one point which I think has not been covered, is something called as PENCAPs, telangiectatic capillaries. And there is a recent paper which is published by Dr. J. Seth from Mumbai and Dr. Rohini Nayar's group from Trivandrum. They are co-authors in the paper, where they have shown that there is a progression of microaneurysms into telangiectatic capillaries. Now, these capillaries typically appear having, bright red center with hyalinized periphery or the hyalinized walls. And if you take a OCT to them, we can see those vessels very clearly in the inner retinal layers as well. So we need to look at that. If there is a lot of exudation and these telangiectatic capillaries are seen, I think doing laser works better than anti-VEGF in these patients. So this is we need to look at that. That is one. Secondly, I think the first patient that that DP showed, I would have probably done angiography. There is a solitary macular cyst which is there, and that is refusing to go away. I would probably look at whether there is any microaneurysm close to that by doing angiography. Again, there are so many factors like age of the patient, willingness of the patient, etc. But in such patients where there are these cysts are not going away, I would probably, I would do an angiography and see if there is any leaking microaneurysm nearby. The second patient that she showed, I would treat because this spongy macular edemas with subretinal fluid and lot of hyperreflective foci, some drill changes. They don't really do well with anti-VEGF to begin. So if I were to begin, I would probably begin with IDEA. I'm not very comfortable giving brolucizumab because of the vasculitis episodes which happen, if they happen. Though it's a very potent drug, but I would probably start with IDEA, or most probably I would give dexamethasone implant in treatment-naive patients as such. So, as far as role of refractory macular edema is concerned, it's an ongoing process. It doesn't. There is no one point stop. You just have to follow these patients up. Sometimes, as the macular edema starts going down, the vitreomacular interface anomalies start showing up on OCT better. So, if there is a traction, we might have to think of doing surgery at that particular point of time. So I think it's an ongoing management that we need to look at, and I think telangiectatic capillaries are something which we all need to keep a watch on, because they definitely do very well with focal laser. And regarding the statins that you were discussing in earlier case, Dr. Amod Gupta sir has published a landmark paper many years back, I think around 20 years back when we were still doing fellowship, where he has shown that 10 milligrams of atorvastatin given over a long period of time really takes care of the hard exudates. Also, if you are trying to dry the macula very fast, the hard exudates can tend to come in the center, gravitate into the foveal center, and that can actually drop the vision. So that also factor needs to be kept in mind when we are treating DAV patients. So these are my few of the comments.
CR sir, I would like you to highlight, especially in this refractory DME cases, sometimes we keep on treating, but we miss a ischemic macula. I agree that FFA needs to be planned midway to revisit and re-diagnose. How does Octa play a role in picking up this particular ischemia component of refractory DME? Because a lot of people, a lot of general ophthalmologists also are upgrading their OCTs to OCTA. Any clues on OCTA to pick that up, and in general to manage the refractory DME?
I don't think OCTA really helps you, especially when the retinal edema is very extensive, because it never segments correctly, and then you can't really see what you assume as no signal is probably just an area of edema. It's just not clearly visible. And so I don't depend on Octa to decide on that. Actually, would be you reduce the fluid in the retina, give an injection, and if it is a more compact retina, then you do an Octa, probably it helps you better. You can kind of understand where exactly the ischemia is. And most often the places where you have ischemia, you don't end up with a macular edema so much. It's usually thinned out. There's drill, which you see on OCT after you correct them. So where there are capillaries, there's going to be edema and there's going to be hard exudate. So most likely, it's just basically as what Manish was clearly saying. What we don't understand is always we look at out the microorganisms, but the disease is actually the capillaries which are, telangiectatic, so to speak. So many times people have, like what you said, FFA. There are people who have actually done ICG along with FFA to see for those most refractive microorganisms, the vessels which actually leak on ICG. ICG is a big dye, doesn't really leak very well in retinal capillaries. But when you start seeing them leaking in those capillaries, you know that that's the area. And those are the areas where you can actually, again, going back to the laser, does a better job than giving you this. The worst part is the first case that she showed, the tiny cyst. You saw that she had 6/9 vision with the same cyst and she had 6/18 vision with the same cyst. So we don't know what actually helped. So we sometimes don't take anti-VEGF so seriously, in the sense we only look at it as it reduces the edema and everything is all right. But it actually does work with regards to improving the neurophysiology. So it actually works. So when we say that, oh, this is refractory, we're not doing much, we actually should look at the visual gain that the patient has. Even if it doesn't look good on the OCT, it does help. And sometimes we don't persist. You can shift agents. That's a great idea. But if you persist along, like she had a difficult patient. She's obviously old. She can't come for injections every other day. So it's a difficult task. But we must insist when we have these things, at least give it a fair trial. And, like they say, at least 3 times you give and see if it works. Then you think of other things like steroids and stuff like that. But what we don't do is, like, we are all clinicians. We are looking at the patient's pocket. They can't afford, so we don't give. That is the most important thing. These drugs are unfortunately have to be given once you start. And because, these are expensive, we have to stop. We can't really give them. It's a catch-2 situation for us.
So there is a concept which is now coming up in many articles about treatment exhaustion. There was
Yeah.
something that we used to maintain the vision of the patient, and there is now treatment exhaustion. So are we waiting for agents like aflibercept 8 milligram or paracetamol for such patients to at least maintain those, especially refractory cases? What is your take on managing the treatment exhaustion part of it?
I think we must not really jump into these heavier drugs immediately. Give it a trial with your regular anti-VEGFs, they do work. You switch over afterwards because it is not easy for you to take your patient directly to a very one is a costly drug. Okay, and these costly drugs don't do magic. They take time to have an effect, which means you have to give them very often till you finally have a what you call long intervals between the injections, which means you have already the patient's lost his what you call money in trying to control the disease. But if you give anti-VEGFs, the older ones, they work well, and if they don't work, then you can always go back to these. You can convince the patient to take these drugs, and it's what they do. People outside, I mean, even in the US, they're all first give Avastin, and then they switch over to the drugs that you're talking about, Vabysmo or Eylea. It's only in countries like UK where they become the first line of drug because the NHS provides them the drug. So it cannot work in an Indian scenario. So you still have to believe in your anti-VEGFs. They do work. There's no doubt about it. As long as VEGF is there, anti-VEGF is going to work.
Thank you. Thank you so much. Thank you, Dr. Dipti, for your presentation, and Dr. Manish for wonderful insights. And with that, let's move on to the next one, Swapnesh.
The next one is a case of CSR with CNVM presented by Dr. Saili Lani from Bombay. And the panelists would be Manoj Sasavade sir, very senior retina surgeon from Aurangabad. Sasavade sir, have you joined?
Yes, I am there. I am there. Yes.
Thank you, sir.
चलो साइली प्रेजेंट कर रहे हैं यार मैं भी प्रेजेंट देख
Good
रहा
evening, everyone.
हूँ गुड इवनिंग
You all can see the slides.
यस साइली यस
Yes, go ahead. Go ahead, Saili.
Thank you, MOS, for the opportunity. And I'll be presenting a case of a 67-year-old male who came with the complaints of decreased vision in both the eyes. Vision in the right eye was 6/36 and in the left eye was 6/60. He's a known case of diabetes and hypertension, and he presented to me on 14 November 2024. Earlier, he has history of intravitreal Pagenex in right eye. 3 injections he had taken, and the last injection was taken in April 2024. And his left eye had undergone PDT in 2012. So on presentation, this was the picture. Right eye vision is 6/36, and there were some RP changes at the macula. The OCT showed SRF and cystoid macular edema as well. The left eye had RP changes at the macula with gravitational tract, and the OCT was completely dry with foveal thinning. So I decided to do FFA for this patient, and he underwent FFA, which showed again hyperfluorescence due to RP mottling, RP defects, and there were 3 leaks which were noted. One is a juxtafoveal leak, and these 2 leaks which were away from the fovea. The left eye, it was again showing just hyperfluorescence due to RP defect. So I decided that right eye I should do laser, but could do laser to the peripheral leaks, the extrafoveal leaks, and not the juxtafoveal leak. Post laser, I could see that the cystoid macular edema has reduced a little bit, the SRF has reduced a little bit, but not significantly. There was no complete drying which was seen, and patient's vision remained same, 6/36. It didn't improve. So after that, I called the patient, but patient was lost to follow-up and came to me after 9 months. After 9 months, when the patient presented, there was a drop in the vision. Patient's vision was 6/60, and the cystoid macular edema was increased. Even the SRF appeared to increase a little bit compared to the last OCT. I saw it on Octa and could see some vascularized membrane like type 1 CNVM kind of thing. So decided to go ahead with anti-VEGFs. This is a picture of pre and post Eylea. The patient opted for Eylea, and post Eylea, after the first injection, the SRF, the cystoid spaces, decreased quite significantly. Second, also it showed after the second injection also it showed a little bit decrease in the cystoid spaces as well as the subretinal fluid. But post third ILIA, there was increase in increase in the cystoid spaces. Patient's vision remained same and there was no improvement post third ILIA. So this is how the patient presented to me, and these are all the pictures of this is the first picture of presentation. Then this is post focal laser after the 9 months when he came back to me, and this is post ILIA. Still he has this cystoid edema and SRF. So what should we do now? Should we repeat ILIA or should we shift to some other anti-VEGF? Choroidal neovascularization is relatively uncommon sequelae of chronic CSR, with incidence estimating about 2 to 9%. But whenever CNVM happens in patients of chronic CSR, it is a major cause of vision loss. Detecting CNVM using FFA in these cases can be challenging owing to the coexistence of features related to primary diagnosis of CSCR. And it is seen most commonly in patients of CSCR who have undergone laser photocoagulation or older patients with chronic CSR, and in patients who have diffuse retinal pigment epithelium loss. So I just wanted to ask the panelist whether should I shift to some other injection or what should I be doing with this patient, because he has hardly shown any response to ILIA.
Sasavadi sir.
Yes, one second. I'm just connecting. Hello, am I audible?
Yes, sir.
Yes, sir.
Yes,
Go ahead.
sir.
Yes. Good. Good, Sari, you have presented a very challenging case. These are very common situations nowadays we are seeing. Previously, simple CSR which we were ignoring just to manage with just a lifestyle disease as if it is a lifestyle disease. But in chronic CSCR, we are now thinking of the pachychoroid spectrum as well as the neovasculopathy along with. That's why they are really improved because of the anti-VEGFs. As the drug of choice usually is brolucizumab, but you have already started with the ILIA. ILIA also does work very well. At least some anti-VEGF is important. In your case, I think you have already tried, and initially you got the response, and again there is a recurrence. Now you can try PageNeck. There is no harm in, and it really works in such situations. The PageNeck is having upper hand over the ILIA. That is what is my experience. The other panelists also can share their experiences.
Sure, sir. Thank you.
Over to Chetan Rao sir.
Yeah, so these are difficult cases to treat anyway, and this is where we are missing out on something which was very important previously, the PDT era. So there again, these are the cases that actually we should be doing ICG. One very important indication is the whole pachychoroid spectrum, the things when it becomes chronic. These are the diseases that needs the ICG testing, because once you do the ICG, you actually can pick out the sick RPE. So the RPE is basically not anymore functional. It's become dysfunctional and is unable to keep the fluid down. And then moreover, you would end up with the usual type 1 MNV, which is what we see nowadays, for which all these anti-VEGF injections are given. So since we don't have a PDT, we started doing ICG and treating them with the low sub-threshold laser.
Okay.
Sometimes yellow laser works. I mean, it's
Yes.
just like, you're just creating a little bit of inflammation in the RP that helps in sometimes reversing the thing. Other people are trying the minocortical receptor, the antagonists. Some people are trying Dimox, but these are things which can have systemic side effects. So we are very wary of that. For example, if you're giving eplerenol,
He
you'll
has
have
already,
Yeah.
sorry to interrupt, but the patient has already taken eplerenol for 6 months.
The problem with that is that after sometimes it becomes refractory. Initially, you see good response, then it becomes refractory. So that drug also you have to check the potassium levels, because you don't want hyperkalemia there. That's a big problem with that. Now, when you give Diamox for a longer time, or the long-acting what do you call Diamox acetazolamide, you're ending up with a hypokalemia. So you're always having these issues. The only way in the presence of ICG we can treat those areas which actually say staining the late films, which tells us that this is the area where there's actually a pachychoroid pigment epithelopathy, which can be treated with PDT. Otherwise, you try laser. I think that's one good thing. And Octa sometimes is not very easy, but CSR is one of the cases where Octa really helps, because that's a case where everything is very clean. I mean, there's no turbidity, there's nothing. The retina is compact, there's just fluid, and RP is not extremely elevated or something like that. Octa in those cases are the best, because you get a type 1 MNV very easily in that. So sometimes we have to keep doing OCT on that. FFA, as she is highly clearly mentioned, is not a very great tool when you see all these tracks and stuff like that. You know that you're not going to get a leak. You have to just assume that this is a leak and treat it. So it's a very difficult case to treat, very, very difficult. And she rightly said, if your CSR has gone into adulthood, I mean, elderly group, which means it has become now very refractory. You can treat such CSRs when they're young, in their 40s or maybe early 50s, but once they go 60s and 70s, it becomes very difficult to treat.
So, Dr. Chetan Rao, what is the Shankar Netralaya protocol? I mean, do you all use anti-VEGFs in chronic CSR? Because, if you use anti-VEGF, what my experience is, you have to keep injecting. Every time you inject, there is some kind of improvement, but then again, it slips into the leakage mode and there is edema there and pachychoroid.
You're right. That is what happens with anti-VEGF. You start giving anti-VEGFs, like usually we give long-acting anti-VEGFs like Eylea, but we as a practice don't use brolucizumab, but people have used that and they have found success. But that's the problem with anti-VEGF. So we have kind of weaned away from anti-VEGF. If it shows response, and then then if it doesn't show response, then again we usually do a lot of ICG for those cases, and then we resort to treating with the laser in cases like that.
Okay. So lasering the leak in these chronic CSRs may still have some promise.
Yeah, they may still have some promise. Yeah.
Okay. Thank you so much. Yes, Saidi, you have something to add?
No, thank you. Thank you.
Okay.
Thank you, Saidi. Stop sharing.
Thank you.
Thank you, Dr. Sasode, sir, for your inputs. And with that, Swapnesh, let's move on to the next case.
So the next case would be an extension of this. Dr. Mahesh Upperkar from Panvel would be presenting CSR and pachychoroid spectrum, and our very own senior Mumbai retina surgeon Paritosh sir would be the panelist for it. Saili, have you stopped sharing?
Saili, can you stop sharing?
Looking forward for a beautiful presentation from Dr. Mahesh, as beautiful as his handwriting.
Thank you, Swapnesh. Thank you, MOS. Is my screen visible?
Yep.
Yeah, okay. So my topic is an extension, as Swapnesh said, of the CSR. The thing is, pachychoroid is something that we are always looking at, but I would like to present two cases where I was really stuck in how to go about treating CSR. So stack of smoke and stories about it. So this is a guy who was a flower vendor from Dadar flower market. Now you can imagine the guy wakes up at 3 o'clock, 4 o'clock every day in the morning and goes and kind of for his flower vending. So this guy had a very disturbed sleep pattern. No wonder he landed up with CSR. Okay, a young guy, when he came to me, this was in about 2012. His vision was fine, but he had that gray patch. Now I did the first thing was to wait and watch. After a few years, I did a focal laser, I think. I don't have those details of that. Till 2018, he was fine with 6/9 vision. But by 2019, his vision had further blurred. The central gray patch had increased. You can see the RP changes. So I decided I'll do a reduced fluence PDT for it in 2019. He showed a brief good response. and the vision acuity was maintained. But you can see that the choroid slide, there is a kind of depression over here, but the fluid is still intact. There is some amount of RP duplication. By 2022, he was lost in that COVID time follow-up. So 2020, 2021, he was lost. 2022, he lands up again with a similar kind of picture, and vision is dropped one line further to 6/12 partial with the persistence of that blur vision. So then I think we were new to this.
Mahesh, sorry to interrupt. I think your slides are not moving. Are you on this slide only?
Sorry, slides are not moving.
Yeah, now they are. All good.
Okay, so I think this is 2022 post-COVID, and vision had dropped further. I tried eplerenone this time, with the caveat that I'll have to keep looking at his systemic parameters, especially as potassium. He did all right for a while. Eplerenone did give a good response, but again, the fluid resurfaced in 2025, and he came back with a further drop in vision. You can note here that the SRF has reduced quite a bit, but the vision is also further dropped. So I did an OCT angio for him to look at what's happening. Why is the vision dropping despite a reduction of SRF? You can see here in the superficial vascular plexus, there is a significant change in the foveal avascular zone texture, with the gaps forming both in the superficial and deep. The choriocapillaries and the choroid texture shows some bit of disorganization, but there is no CNVM as such. So this was a unique case where there is a drop in vision without a significant increase in the SRF. So my questions came up with for this case was, if there is a reduction of SRF despite maximum therapy, and yet you have a drop in vision, what are your treatment options? And for a progressive drop in vision with anatomic changes in the foveal avascular zone, which I did not expect, how would you here start treating this patient? So this is my first case. I'll quickly present my second case, and then we can have a discussion. That is not my patient. That is a person I admire for his masterful inactivity. So this was a case of masterful inactivity, but I wanted to really treat this patient. This was a 60-year-old female who was suffering from interstitial lung disease. Now, since a long time, she was on multiple antifibrotic agent, methotrexate, multiple immunomodulators. And about last 2 years, since 2023-24, she was on steroid inhalation, budesonide, for quite some time. Almost every day, she used to take 2 times budesonide. 2025, she reported with blur vision in both eyes. And this is, you'll understand why that smiling face of Narasimha Rao, because this is the presentation of both eyes. I said, stop your steroids. This is the presentation of both eyes with the PED, serous PED and SRF. Then I started giving Eylea. I said, no, let me try something different. I gave Eylea in the right eye. Let me try something different for you. Steroid stopping has not helped. The clinical picture is the same. The vision was 6/12 partial, both eyes. The PED is the same. And this is about 8 months post the stopping of steroids. She has used some different, I think, salbutamol variant for her inhalation. And post Eylea also, this is now 3 to 4 months. There is absolutely no change in the PED. So questions regarding this is, if you have a symptomatic PED, which is unresponsive to any of your treatment, how would you approach it? And if you approach to start treating this patient, when a tense serious PED, what would be the things that you would look out for in this case? CR sir?
No, your discussion is there.
Acha, Kamdar sir hai?
Yes.
He's there, he's there.
Dr. Kamdar sir, welcome.
He's there?
Thank you. Good evening.
Yeah.
Sorry, I was late.
No, sir. Go ahead, sir.
Thank you. So let's go back to your initial this thing. Okay, keep your slides on, please, if you don't mind.
Yes, sir.
first thing is what is I mean, I normally, whenever I approach any of these patients, I start with their occupational background as well as psychological background and their background circumstances, both at home and workplace. Uh, and try to mitigate whatever levels of stress that we understand. And I ask them to undergo, changes in their own lifestyle, attitude, and all those things that we are well familiar with. The other things I also look out for are things like any inflammatory, background things happening in their body by doing things like an ESR and a quantitative CRP, and also a homocysteine for people who are pure vegetarians. Now, let's presume that all that is normal. There is no great amount of stress and all, which is very unlikely. There would be some lesser or greater amount. Uh, uh, Often they are able to manage it. If we find on repeated, I mean, I'm going beyond, like prior to your situation where you had to do affluence PDT and all. Okay, I'm just starting right from the beginning in this case. So that is how I would go about. Now there are some cases where you realize that yes, things are not likely to. I mean, they're unlikely to change. Even if you involve any psychologist or a psychiatrist, you give them any, some of them might be plain depressed, and might be anxious along with that. So sometimes the psychiatrists are able to, apart from anxiolytics, give them some antidepressants and all, and that might turn them around. But let's presume that the patient doesn't have those things or has some kind of chronic stress and lands up with this kind of a situation where there is persistent fluid and an RPD and all. So one is, you already did an OCTA. So either an OCTA or a dye angiography. If a dye angiography, then I would do both FA as well as ICGA and then take my calls. Now, choroidal thickness, average choroidal thickness, I mean, the cuts are not complete, but it appears to be, what was the age of this first patient, by the way?
When he started off, he was 45, sir. Now he's nearly 12 years with me. So he's
Yeah,
now
so one more thing which I found in many of these patients with pachychoroid, that is thickening of the choroid with sclerosis of the large vessels, is they have dyslipidemia and also metabolic stress, and many of them also have some lesser or greater degree of sleep disturbance. May not really be a proper sleep apnea, but sleep disturbance. So that's the other thing also which I ask them to check up. If there is sleep, I mean snoring, for example, then I tell them a very simple thing that use a wedge pillow of 5-inch or lesser height if available, and sleep on the sides. And a lot of patients that gets sorted out. But a very, very, very important thing here is to sit down with them. I mean, according to me, these are patients where I think I'm doing a lot of psychiatry or psychology on the patient as than being a retinal specialist at that time and urging them to bring about a lifestyle change. Now, let's presume everything has been done, nothing worked. You corrected whatever metabolic factors which were abnormal, and yet one lands up with this kind of a scenario. Then, yes, I agree with you. I would also consider a half or even quarter fluence PDT. It helps. Now, prior to that, there's just one more thing which I also do, and that is to give them dorzolamide or brinzolamide eye drops. And if the patient's pulse rate is is not less than 60, then I also add timolol to it, and provided he or she is not having bronchial asthma. The logic is that this is a sclerosed, large vesseled choroid, which is compressing the middle and the smaller choriocapillaries and is creating some kind of a choroidal or and outer retinal ischemia. So if we are able to deturgis the choroid and then it would help these circumstances. So that is the logic behind this. And the second thing is that the brinzolamide or dorzolamide, it will inhibit carbonic anhydrase at the level of the RPE and help to pump out the subretinal fluid a little faster. So that's the logic. And in addition, I would also give something containing resveratrol because it's known to help to reduce apoptosis of the photoreceptor cells. So these are all empirical. If you ask me any clinically controlled trial and all, no such thing is available. I mean, I don't, meaning there are no trials to the best of my knowledge of any such thing. So, hello, am I audible?
Yes.
Yeah, sir. Yes,
Yeah.
sir.
Yes, sir.
Yeah.
So that is that. So, if PDT is not available, my other go-to is to do an ICG enhanced TTT using extremely low-powered, large-sized spot, transpupillary thermotherapy thing, and that is what I would do. But that I would do it with a lot of caution, and obviously I would keep a watch on the OCTA because some eyes with persistent fluid, they tend to develop these choroidal neovascular membranes, as you know, particularly the eyes with this kind of a humped or a multi-lobed RPED that you see in this picture. Can we go on to your next slide, please? Then, and eplerenone, of course, I mean, that would be my sort of last resort. But to be very honest with you, eplerenone has not really worked out very well in some of my cases. One more thing that one would like to use would be anything that stimulates some of the liver enzymes, and particularly something which stimulates cytochrome P450. So there are some dietary factors like broccoli and some others which I've forgotten at this point of time, which help to stimulate those liver enzymes, or even simple this our LIV52. That you see the if you are aware that in some other places outside of India they use rifampicin for chronic CSR patients also. We don't use it because there's a very high risk of creating rifampicin resistant tuberculosis. It already exists. We may just end up worsening it. So the rationale behind using rifampicin is it stimulates this cytochrome P450 in the liver, which breaks down some of these, the corticosteroids which are triggering this. So that is the logic behind that. So I do it the other way now. Dr. Chetan Rao would be much more, and Preetam and the others would be much more well-read than me. So maybe they can perhaps add to whatever I have said. So I'll leave the floor open to them for this now, before we go on to the next case.
No, thank you. Thank you for the valuable insights, Dr. Paritosh, sir. So, Dr. Chetan, you have these bilateral PEDs as seen on the screen here. You have a little bit of subretinal fluid under the retina over the PED.
Preetam, before we go on to that, does Dr. Rao or you or any of the other panelists, do they have anything to add to what I have said for the first case?
Yeah, that's what I'm asking. That's what I'm asking, Dr. Chetan. I'm asking, how do they approach? How would they approach something like this? Because this patient obviously is having a lot of metamorphopsia, bilateral PED is there, and he's bothered, right?
Yeah, so this is a very tough question to answer because we won't be seeing this phenotype very often, and that too bilateral. It's a very rare, what do you call, combination that we're seeing bilateral with this kind. There's no real answer to it, but yeah, what Dr. Paritosh is saying, what we can basically is again we are showing a RP which is not functional at the tip of the summit of the thing because it's now it's pretty high. And what everybody tries to do is give things like Dimox. I think we really don't have a treatment. We can't do laser. We can't give steroids. There is a particular group, I think LVP and all, where they actually proven that they are given steroids, injectable steroids to correct this, not systemic steroids to correct this. So, but I'm not really convinced with that argument. They say, as he says, no, there is some inflammation going on. So people believe that there's an inflammation and hence this thing is happening and you give an a steroid inside the eye. But I would probably shy away from that. But in this case, Dr. Paritosh said these are the cases where we spend more time counseling them than actually offering them real treatment because ultimately we just end up giving them a Dimox eye drop or a long standing thing. I'm not sure any anti-VEGF will work in this kind of condition because you have seen with or without it remains the same.
Absolutely. You give the anti-VEGF, there is a little bit of reduction in fluid, and then again it comes back. So, the story just continues.
Yeah, so this is some patients that we are very wary of in the clinic. When we come, we know that we're going to spend at least 45 minutes with them, trying to convince them that this is a different as a disease which is probably having no treatment unless it has a complication.
True.
So
Thank you, Dr. Chetan. Yeah.
Just one more point, since we mentioned about some people responding positively to such cases with steroids and some others not. I would also inform the patient that the root cause is the genes, because otherwise everybody with stress should manifest this way. Everybody with stress and metabolic dysfunction should manifest this way, but it doesn't. Now, in that gene thing, I'm sorry, I've again forgotten those specific names of those codons and all that. But some they will worsen with steroids, but there's a very small subset of eyes which will actually improve with steroids. So a safe midway path would be to try and use NSAIDs in these cases, if at all one wants to think in those terms. But again, it's sometimes just acting as a placebo.
Thank you. Thank you so much, Dr.
Thank you.
Paritosh and Mahesh. And with that, let's move on to, I think, our last case for the evening, right, Sapnesh?
Yeah.
We have
So
Sagar.
last
Dr.
case,
Sagar. Yeah.
Dr. Sagar Huibar from Akola would be presenting a case of retinal vein occlusion. And Dr. Nitin Prabhudesai unfortunately couldn't join us. So I would request Dr. Pritam sir and Dr. CR sir to be the panelists for this particular case.
Sure. We can all contribute. We have all eminent panelists today. Go ahead, Dr. Sagar.
Thank you. After these very brainstorming, are my slides visible
Yes,
and
yes,
audible?
yeah.
Yes.
So after all these brainstorming cases, mine are pretty simple day in, day out cases for retinal vein occlusions. I was told that the target audience would be general ophthalmologist fellows. I don't see many of them over here, sadly. So I have intentionally kept the so-called high funder investigations of Octa and FFA, which are routinely not available, away from this discussion. So I'll directly jump into these cases. This was a 70-year-old pseudophakic Asian male presented to my clinic with a history of 45 days of diminution of vision in his right eye, a diagnosed hypertensive and an habitual smoker. The visual acuity recorded was 6 by 24 N18 with clinically evident inferotemporal BRVO with clinically seen macular edema with hard exudates and a recorded IOP of 14 millimeter of Hg. The systemic investigations, what we routinely advise that I'll come to on later, were essentially normal, and the OCT showed a large area of cystic space subfoveally with preserved outer retinal layer. Now, considering the pseudophakic status, the amount of macular edema on OCT, and the duration, considering it to be a chronic already 45 days history, I advised this patient. I advised this patient a combination of anti-VEGF, which was Avastin in this case, and an cocktail shot of triamcinolone acetonide. The central OCT, which is 6 weeks after the first shot, showed an very significantly reduced macular edema with a string of hard exudates still visible. The vision had improved to 6 by 12 parts and N8 after 6 weeks. Now, meanwhile, I have also examined the patient once between these two visits, and I could see that the IOP has spiked up to 20 to 24 in that injected eye. So I have started the patient on anti-glaucoma medication, BD, and with that medication, the IOP was means brought back to normal, 14 millimeter of Hg. I have sequentially followed this patient for almost 9 to 10 months. And the bottom is the September 24, almost 10 months after the presentation. We can see that the foveal anatomy is absolutely normal now, and even the hard exudates have resolved. The IOP is very much under control of anti-glaucoma medication, which I have stopped in between in the follow-ups, where I could see now that after withdrawing the anti-glaucoma medication, the IOP was not again spiking up. And the vision has almost restored to 6 by 6 and 6. So this was one patient of a typical branch retinal vein occlusion, responded beautifully. Probably the reason for this patient responding in spite of having so much macular edema was the preserved outer retinal layer, which I would like to highlight is a very essential OCT marker for prognosticating in these patients. The second case is again a young male patient, phakic, presenting with history of 5 days reduced vision in the right eye. He was already a diagnosed case of ulcerative colitis systemically on azathioprine. Clinically, in the affected eye, the vision was 636 and 36 with the CRVO like fundus picture. Clinically, considering the amount of hemorrhages, extent of edema, the disc look, and the fundus appearance, I was anticipating that could be an ischemic variant with massive macular edema, flame-shaped hemorrhages, and presenting IOP of 16 millimeter of Hg in the affected eye. The systemic investigation showed that he was severely anemic and deranged LFT. Probably I could correlate these investigations with the azathioprine, which he was on for his systemic ulcerative colitis. The OCT showed a combination of neurosensory detachment with large intraretinal cystic spaces, macular edema of almost an CFT exceeding 700 microns, and also a hyperreflective inner retinal layers. Could also be some arterial component involved in it. Now, considering the phakic status, as well as my recent experience with the recently used newer anti-VEGF and the affordability of the patient, who was very keen on getting his vision back, gave this patient an option, and he opted for it, injectable faricimab. Now, he presented to me mid-April. This is almost 30th May 26, almost 8 to 10 days back. The complete edema has resolved with a single injection. Almost the foveal anatomy is completely restored with some residual cystic spaces. And the vision has been miraculously restored to 6-9 parts and N8, in spite of me suspecting some sort of arterial component, arterial occlusion, as well as considering the increased reflectivity on the presenting OCT. Now, clinically, we can very much see that the cotton wool spots have popped up, clinically signifying that probably there could be a large amount of peripheral ischemic component to it. So I am expecting and anticipating a recurrence in this patient, and I am keeping a close watch for peripheral ischemia and probably be a aggressive PRP if needed in this patient. So these were the two patients. The main purpose of putting these cases across was in simple cases of BRVO as well as CRVO, with macular edema being the most important cause for poor vision. In fresh cases, I prefer using the anti-VEGF groups with all the drugs. Even right now, almost majority of my injections are still Avastin, the time tested and the most least expensive one, followed by ranibizumab, aflibercept, and now even faricimab, which is available. I prefer using long-standing in patients where long-standing edema is there or refractive, or even in de novo cases where I feel that the edema is much high. I prefer using either isolated or an combination shot of anti-VEGF with steroids, preferably triamcinolone. Patients where retinal ischemia is there in these patients, lasers play a spectacular role for preventing the long-term complication as well as reducing the injection burden and recurrence in these patients. For patients where already long-term complications like vitreous hemorrhage, tractional sequelae are there, vitrectomy would save a day for us in these patients. So, while evaluating these patients, we have to think beyond the eye, since retinal vein occlusions are an ocular manifestation of a systemic problem, with hypertension being the most common risk factor, diabetes mellitus, dyslipidemia, lifestyle choices like smoking and alcohol, even ocular disease like glaucoma would be a causative factor in some of the BRVO cases, and cardiovascular disease. So while evaluating along with the ocular investigations, one need to systemically and thoroughly investigate these patients as per the suitable profile, whichever risk factor is present. And the ocular investigation, as we have already discussed along with the cases, they help us to quantify the edema and ischemia if present. Prognosticating these cases becomes really easy with OCT, with the outer preserved outer retinal anatomy on OCT. Would certainly these patients respond to better in a better way to anti-VEGF, and would translate that improved recovery on OCT to visual benefit. And OCT along with Opta also play an important role for follow-up and judging the response to the offered treatment. So my take-home messages from these cases would be that early diagnosis and treatment with anti-VEGF and steroids in RVO-related macular edema ensures maximum probability of visual gain. In my opinion, intravid steroids, if used judicially in selected cases, play a very crucial role. I am a very avid practitioner. Some of might of you not agree with it, but in my practice, I very avidly use Avastin along with triamcinolone acetonide, because affordability is one thing which I have to keep in mind while treating my patient pool, which is a very important factor in a tier 2 or tier 3 city. So steroids help to reduce the edema, and Avastin or rather any anti-VEGF would take care of the VEGF drive which is hyped up in this patient. And also in my experience that an anticipated or an aggressive peripheral laser, especially in CRVOs, helps to reduce the injection burden in these patients. And OCT play a very crucial role in prognosticating and follow-up. So thank you.
Great. Dr. Sagar, you've done a fantastic job. You've presented two classical cases of RVO, branch vein occlusion and central vein occlusion. You've you've really highlighted and in a nutshell everything, and you've been honest also about your approach. Thank you for that. So I think when we look at retinal vein occlusion, the management is not only ocular, but we have to look at the systemic aspect. All the systemic risk factors have to be thoroughly investigated and treated. The local risk factors like raised IOP, if at all, or a primary open angle glaucoma has to be treated. As far as treatment of branch or central retinal vein occlusion goes, I think any kind of laser to the macula is out of the window right now. We had the central vein occlusion study, which already said do not laser the macula. Before the anti-VEGF era, we used to laser the macula for macular edema in branch vein occlusion. But now that also has taken a backseat because of, the fantastic pharmacotherapy that is available at our hands. So I think the whole premise of treating macular edema in retinal vein occlusion, you go back to the Bravo and the Cruise trials, which were the first trials done in anti-VEGF for anti-VEGFs, the ranibizumab, and the Bravo trial, which showed almost 17 letters gain in branch vein occlusion, and the Cruise trial, which showed at least 9 to 10 letter gain for central retinal vein occlusion. I think these are the pillars or the premise of treating retinal vein occlusions. Yes, if I would slightly differ in Dr. Sagar's approach, that I would reserve my steroids for when the macular edema enters into a chronic phase, especially with CRVO or even with BRVO. If the macular edema after 6 months or a year is entering into a chronic phase, probably that time I would choose steroids and a shift to steroids from anti-VEGF. My primary line of treatment would still be anti-VEGFs. And the other things is the role of sector or pan-retinal photocoagulation will come into the picture if there is neovascularization in any of the situations. In branch vein occlusion, if it is a neovascularization elsewhere, or in CRVO, if it is a neovascularization or anterior segment neovascularization, then you have to prevent the sequelae like neovascular glaucoma or vitreous hemorrhage by doing sector laser photocoagulation or pan-retinal photocoagulation. So these are my inputs, and over to the other panelists, Dr. Chetan Rao, for your comments.
Yeah, so I think this is one of the most, honestly being the least controversial, what do you call, disease to treat. We all know how to treat it. And we all
I've created one controversy.
we all do
Chetan,
what
we kept a simple one for the end.
yeah. This is the easiest and the best way to do it is this, like you said, very we all of us, most of us will actually start with an anti-VEGF, and as simple as Avastin, the first drug which has been used by Sagar, is as effective as the newer drugs that we give. So anti-VEGF, this is the one treatment which is unlike DME, where we have to continuously monitor and keep injecting, and we're not really sure of the visual benefits. In CRV, you actually do a magical benefit. If there's no ischemia, you see the edema melting away with anti-VEGF, and you actually see a vision improvement. And ideally, the only important factor is that it has to be treated as early as possible. I mean, there is no question of us that we wait for some time, like we used to do for a BRVO, the trials and all this, that you wait for 3 months and stuff like that, and then do the lasers. Here, the minute you see RVO, you look at the systemic factors. If he has a diabetes or hypertension, correct that. I mean, at least start it simultaneously and then go off with the anti-VEGF. So the mantra in this case is to give the injections as quickly as possible. If you're comfortable with steroids, give steroids. But I would still feel most of us are comfortable giving anti-VEGF, and they are the best. They are the drug of choice. And treat early is the mantra, as Sagar has rightly pointed out. And all of us have different practice patterns. I mean, practice pool, or to say so to say, patient. So obviously, so many anti-VEGFs are available in the market. We can choose any one of them, and most of them will work.
Thank you, Dr. Chetan. Any comment from Dr. Paritosh or Dr. Sasade, sir?
Oh, this second case, he was a young fellow on azathioprine, and so I would also do an ANA for him, and I would also do C Anka, P Anka. So if any of those elements are positive, then he would need further and higher immunosuppression. Second thing, I agree with Dr. Chetan Rao as well as with Dr. Preetham that I would hold back the steroids till it becomes absolutely essential in an injectable form. Okay? Only when it goes into chronicity, I would add that. Please.
The thing is that,
Thank you. What is your
yes, Sagar, you have presented a very wonderful, surprising results. Basically, in a one shot, I have not come across any case of CRVO or a BRVO resolving to such an extent. Very interesting. Either it is related to most of the times if CRVO associated with homocystinemia or any systemic factors resolves, that's known. But BRU obviously will not resolve in a one shot. Even simple tributary vein occlusion, macular tributary vein occlusion takes years together. We keep on injecting every 2 monthly, even doing the grid laser, and still the edema keeps on coming. That's why wonderful results in your case. As far as the steroid versus anti-VEGF is going on, the non-ischemic CRO at the earliest, if you give the Ozurdex, it works very well. That is what it was the first line of treatment in my cases few years ago before this Eylea and came into the market. That's how it works if it is given in as early as possible. And apart from that, anti-VEGF plus lasers do work. Laser in BRVO cases has a definitely role. While in CRVO cases, once it is converted non-ischemic to ischemic, obviously you can think of giving the lasers also as early, because anyhow it is going to create a problem in future. That's why wonderful results in your case. You have to. My challenge is that investigate why these types of results you have got. It's not the only thing that the posterior retina or all those things layers are good. In many cases, this is good. Even in diabetic cases, RP pumpy is good. Still, we won't get such types of results. So the challenge remains that to find out the etiology, exact cause of this VRUs and CRU.
Yes, sir. Means BRVOs, macular BRVOs are quite tricky and sticky because we keep on injecting and they keep on recurrence edema. Sir, even in my practice, primary line of treatment, the first line of treatment is anti-VEGF. But what I meant with those slides was I don't hesitate combining it with steroids in selected cases. So
Absolutely.
primarily anti-VEGFs and means to be honest, I am often very strong opinion that the tendency for IOP spike with intravitreal steroids is more feared than practical because almost 60-70% of the case you won't have anything, and the remaining 30-40 of the 30-40% of the cases the IOP spike would be such that it will be very easily controlled with a single drop. And my approach for these cases is that I want to reduce the injection burden because only with anti-VEGF, as I have experienced that many a times you need multiple injections.
Yeah, that only one thing in this steroid, you have to take care that many cases of CRO, BRO is having already pre-existing glaucoma. And second thing,
Yes,
if
yes, yes.
hyperopic disc at a risk, what we say, in those also, if slightest rise of pressure also can lead to the AI1 type of things. And I have come across that, and I have to operate one case for a rise of pressure because of the IVTA.
Great. Thank you so much. Swapnesh, this was the last case we had done, right?
Yes.
Great, great.
So I
So,
think we have come to the end of the CME.
yes, I
Would
think we
just
had,
like to add that
go ahead.
Sagar had both the cases.
Yes.
Sagar, your both the cases were male patients. Had it been young females, then PCOD,
Yes.
and we would have gone in that direction of investigation. Also, I would add to Paritosh sir's line of investigation for a young RVO, APLA also should be kept in mind.
Sir, he was already under the care of an rheumatologist for his autoimmune disorder, and they have thoroughly investigated him, and he was already on immunosuppression. This drug was one which I could see in his prescription, and that was also it was modified regimen. Means initially he was on many drugs, and then they have toned down just to azathioprine.
Yes, but in such cases, you have to see for the rebound edema. Rebound edema is,
Yes.
even though you have got a very interesting results, may not be the end of the case.
Yes, that's what I was anticipating seeing. Means this was like a classical thing from the textbook what we were taught during our MS days. That if you see any vascular pathology where the number of cotton wool spots are more than 5 to 6, you anticipate that it's of an ischemic variety. So I was anticipating recurrence as well as probable need of PRP in this case.
Yes.
Sir, he is anticipating recurrence. So he will inject again and he will laser.
Yes, sir.
So, thank you all the
Yes.
panelists, Pritam sir, Anaga madam, for joining us and having a feast of discussion. Thank you all the speakers for being ready to speak at a very short notice. CR sir for taking out time and giving his inputs. Pritam sir, last words by the president.
No, I would like to thank, before Dr. Anaga takes over, thank you, Dr. CR, for coming and giving your valuable inputs. To all the panelists, Dr. Parito sir, Sasade sir, dear Dr. Sharad, and my dear friend Manish from Nashik, and to all the presenters, Sagar, Saili, Dipti, Amit, and dear Mahesh. Thank you one and all for a wonderful evening, very informative and lucrative. And over to Dr. Anaga for the final words. I have already thanked Dr. Anaga and Dr. Swapnesh for the wonderful program.
And thanks to Swapnesh and Pritam for organizing such a wonderful discussion. Thank you.
Yes, yes, absolutely. Dr. Sagar, can you please stop sharing?
Yes, yes.
Yes, actually, it was a wonderful webinar, and I'm sure a lot of doubts would have been cleared in the minds of our viewers. Will have taken a lot of efforts to curate this program with an excellent case presentation style and a lot of discussion. So, a lot of information and a lot of learning. So, sincerely thank each one of you, Dr. Chetan Rao sir, Dr. Pritam, uh, Dr. Swapnesh, Dr. Manoj, Dr. Mahesh, Dr. Manish, Dr. Paritosh, Dr. Sagar, everyone, Dr. Amit, so Deepti. So thank you so much. Sorry, there would be a lot of commotion around here, but I'm sure it was a great one. Thank you so much.
Thank you.
Thank you. Thank you.
Thank you,
Thank
ma'am.
you. Thank you.
Bye.
Thank you, everybody.
Thank you. Good night.
Good night.
Thank you, CR sir.
Thank you.
Thank you, Kamdar sir. Thank you.
CR sir.
Thank you. Nice case, huh, Mahesh? Thank you. Nice
CR
case.
sir.
Thank you.
Thank you.
Bye.
Pritam, Swapnesh, thank you. CR sir, see you. See you soon.
Yes, boss.
Manish sir, thank you for hanging around.
Thank you, CR sir.
Thank you.